Hi, everyone. My name is Kevin Dixon. It gives me pleasure to introduce Andy Herber. I'm probably not going to read his biography over again. I feel like everybody that's here was at the electrolyte session, but I do want to take this opportunity to point out that the general feedback from that electrolyte session was extremely positive. We're very glad that you've joined us today, Andy, and we look forward to another amazing, right? Just so you know.
All right, thank you. You guys, good to see you back. It's always the toughest spot. Last day of the conference, right after lunch. It's usually like turn and burn time, but I'm glad you guys came back and hopefully I can teach you something. I went through the slides with Christy, so hopefully all the audience response are up there on this one. So we'll work through these cases very similar to the last presentation. I'm assuming most of you were at that one, or at least the faces all look similar. So this is a throwback to Garth Brooks here. Stole that, changed the lyrics a little bit here, but this is going to be very similar to the electrolyte presentation, but these are all going to be presentations of low platelets and how do you manage those patients. Again, I have nothing to disclose. I have 4 kids at home. So again, I'll take all the money in the world to fill up my minivan with gas and take care of all their expenses. So the learning objectives here, we're going to talk about thrombocytopenia. And this, again, I work in hospital medicine at Mayo in Rochester. So most of these cases are going to lean a little bit inpatient. We're going to talk about workup. We're going to talk about management. And then I'm sure Garth Brooks is probably going to be in your head a little bit after this. Pre-pandemic, before when we were recording sessions and then, you know, it's no secret that CME events will record these sessions and then sell them down the road. So once that transition for CME started to happen, then you couldn't include a bunch of trademark or copyright images. I used to have Garth Brooks kind of songs throughout this presentation, but unfortunately can't do any of that, or unfortunately or fortunately, depending on which way you kind of lean on country music there. So anyway, we'll start with the basics again. This is right out of Up to Date, so you can't see it. The print is super small, but we'll go through all of that. But when you think about thrombocytopenia, the most common things that cause it is going to be decreased production. So is there cancers or viral infections or chemo or alcohol, and increased destruction. So ITP, these are all those acronyms that are super scary. ITP, HIT, DIC, all of those that we'll talk about in a little bit here. Increased consumption, dilutional, sequestration, drug spurious. So all of these cause platelets to go down. And so we're going to talk about that throughout the next like 45 to 50 minutes. When you look at workup, again, this is a very dated slide from 2012, but one you can kind of follow. But again, I can't stress enough that patients don't check out this chart before they get admitted to the hospital and make sure that they do exactly like the chart says. So again, I took a bunch of cases that I've taken care of at Mayo and Rochester, changed the names around, exaggerated some things, hid some things so that we can learn how to manage thrombocytopenia. And then I'll just have you guys sit back. The audience response should be working much better this time, or at least a question should be coming up, and then have you guys help me out. So we have Mr. and Mrs. Spots, we have Mrs. Popcorn, Mrs. Chemo, Mr. Ito, Mrs. Sofa, Mrs. College, Mr. Seymour, and Mrs. Heparin. So the first patient is Mr. Spot. So like Caucasian, 44-year-old male, no past medical history, he had his tonsils taken out, I think when he was like 8 or something like that. He takes ibuprofen, 800 milligrams every couple of hours, mostly after like being a weekend warrior type of guy. So tries to play basketball and stay in shape, and then takes a bunch of ibuprofen after that. So over the last 24, 48 hours, he's been having bloody nose that he's having a hard time stopping. And then he started noticing tiny spots on the bottom of his feet, and specifically said, well, other than ibuprofen, that's all I've been taking. And then I have not had a fever. So he shows up in the emergency room, and here's his lab. So his hemoglobin's fine at 160. His white cells are okay. His platelets are pretty low at 22,000. And then everything else kind of checks out and is okay. So other than the bloody nose and spots on his feet, he said he wouldn't be here. So my question to you is, what's the next best step to take care of him? Does he need a peripheral smear? Should we jump right to bone marrow biopsy on him? Does he need some platelets right now? Does he need plasmapheresis? Or do we friend request a phlebotomist on social media? Smear, yeah, fantastic. So always, when you're talking about new onset thrombocytopenia, it's kind of like a reflex. So if you see platelets that are low and it's new, getting a smear is probably always going to be a great option for you. So you get a peripheral smear on him and you have absolutely no abnormalities. So my question now is, what do you want to do? So he's down in the emergency room. He's got a bloody nose. He's got a platelet count of 22,000. Do we just keep an eye on him? Do we start dexamethasone? Do we start IVIG? Do we set him up for plasmapheresis, or do we take his spleen out? And these are based on the American Society of Hematology guidelines of 2019. This is probably ITP, right? So this is a young person, only cell line that's low is the platelets. Everything else looks okay. And he's just walking into the emergency room. So now we have ITP as the diagnosis. And now we need to know, what do you do? When do you treat ITP and when do you observe it? And so if you look at the American Society of Hematology guidelines, they would say you treat anything less with a platelet count less than 30,000. So he fits that. So I would start some dexamethasone or some prednisone on him. And then the question is, then where do we treat him? So we know it's ITP. We'll talk about that in a little bit. We know we need to treat him because he's less than 30,000. So he would, based on evidence-based medicine, we should treat him. So do we treat him and street him as far as send him, discharge him from the ER, or do we admit him to the hospital? And again, this is the consensus guidelines from the American Society of Hematology in 2019. There's 22,000. What do you think? Inpatient or outpatient? It's actually, yeah, it's outpatient. So 22,000 is pretty low. It's pretty scary. Now, this is guidelines. Now, if you told me this was a 90-year-old who lives by himself, who's 45 minutes away from any emergency room, who's falling all the time, obviously the guidelines probably aren't going to come into play here. But if you did exactly evidence-based medicine on this young, reliable 46-year-old who lives pretty close to the emergency room, you could send him home and have him follow up with his outpatient provider. So this is ITP, most common cause of isolated thrombocytopenia. Again, what are some things that we're seeing here that's not so worrisome? It's isolated thrombocytopenia. All the other cell lines are okay. Otherwise, pretty healthy person and pretty minor symptoms. 5 cases per 100 in the US. Drug-induced is usually the cause, and it typically happens about 2 to 3 days after exposure. And there's a bunch of management for it when you get into the complex. So if they don't respond well to like conservative therapies, then we can talk about all this, which is outside of the scope of the presentation, but at least mentioned here to look up. So you take care of him and you say, hey, buddy, we're going to give you some prednisone or some dexamethasone and you can go home. And then his wife says to me, whoa, 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 whoa. If he's got that, then I probably got that because I've been next to him the whole time. And you're like, you know what? ITP, it's not contagious. You don't have that. She's like, no. I'm pretty sure I have it. And we're like, oh, did you have any symptoms? She's like, no, just draw my blood. So again, Mrs. Spots she's got no past medical history, no past surgical history. She takes some melatonin at night. And then she, like I said, she's nervous. She has it too. So you look at her labs and they're the exact same as the husband. I got you leaning that way from the other presentation, but she goes, I told you guys all wrote me off. I told you I had this. Now you need to treat me too. So my question to you is, you get a peripheral smear on her, because you remember from the previous presentation that new onset thrombocytopenia, get a peripheral smear, and this is what you see in peripheral smear here. So lots of red cells there, some platelets that are hanging out, a couple of white blood cell neutrophils. Anybody that worked in lab medicine before that probably recognizes what this shows. But my question to you is, what do you do for Mrs. Spots? Does she get Dex? Does she get IVIG? Does she get plasmapheresis? Does she get splenectomy? Or do we friend request a phlebotomist on social media for her? Exact same case, just a different peripheral smear. A little aggressive. I would friend request a phlebotomist here because we needed the phlebotomist to come back and draw blood again. So look at this. What do you guys see on here? What are those platelets doing? That's platelet clumping on peripheral smear. So if you're seeing platelet clumping, a lot of times it's from like a traumatic tap or somebody that maybe is responding to like the EDTA that most CBCs are drawn in. And so what you have to do is end up drawing these in a sodium citrate or a heparin tube after that. So a lot of times, most common cause for platelet clumping, and this is usually going to be read to you on the peripheral smear. So new new thrombocytopenia, and they're probably going to say platelet clumping from the tech. But this is either traumatic venous puncture or EDTA-dependent antibodies, which react with platelets, cause them to clump. They're really all there, but they're all just clumped together, and the analyzer is counting them as one platelet. And so the treatment for that, or what you need to do, is just repeat that in sodium citrate or heparin. And then the difference there between the two cases, if you're saying, well, why didn't we do that with the first one, is just the change in peripheral smear. So basic ITP, no changes on peripheral smear, just isolated thrombocytopenia. And platelet clumping here would say, hey, let's at least redraw in the right tube, or at least make sure we don't have a traumatic tap before we end up sending her for any more aggressive therapies. All right, good with that one? Here's Mrs. Popcorn. So she's got diverticulosis, hemorrhoids, coronary artery disease with a stent. She was recently hospitalized on our service with a UTI with a bloodstream infection. She's got a PICC line in. She's had a right total knee replaced. She's on aspirin, metoprolol, atorvastatin. She's on ceftriaxone for E. coli bloodstream infection. And then she's got PICC site cares at home with heparin flushes and saline flushes, and the home healthcare nurse doing all of that. She's been having some painless rectal bleeding for at least 4 days now. Her PICC site cares have continued at home, and she didn't want to catch the COVID, so she didn't come in. So she just sat at home and continued to bleed. Finally, she got so weak and hypotensive that she showed up in our emergency room with a pretty profound anemia of 5.8 or 58, and an AKI with a creatinine up to 150. So we got a bunch of bleeding, and we got an AKI, and a patient bleeding from the rectum, and then she's on heparin, flushes from her PICC. So the question is, do we transfuse her or not? And the answer is 100% yes. I think last year maybe I did the anemia presentation, but just real quick here, we know from a bunch of evidence-based medicine that restrictive transfusion strategies definitely win out over liberal transfusion strategies, whether that's in GI bleeding, 7 versus 9, or hip fractures, 8 versus 10, or septic shock patients, wins that magic number. And, you know, at least in the States, we shoot for 7. So symptoms will always trump that. 7, 70, I think, for you guys. But anything below that, we would transfuse. So she obviously fits that. She's 58. And so we gave her a couple units of blood. So after her couple units of blood, her hemoglobin goes up. Now her platelets are down, and her creatinine is improving a little bit. So same lady, improving hemoglobin, rectal bleeding has stopped, but now she's got thrombocytopenia on hospital day 2. My question to you guys is, what do you do next for her? Do we get a peripheral smear? Do we stop the heparin flushes to the PICC lines and then draw a PF4 antibody, which is helpful for heparin-induced thrombocytopenia, and then start her on a gatraban? Do we repeat this draw on sodium citrate like we did with Mrs. Spots? Do we transfuse platelets, or do we take some 3-day-old pizza from the nursing break room? I feel like my threshold for how long of pizza has increased after the pandemic. So like in pre-pandemic, I'd be like, I'm not eating that if it's been there, but post-pandemic, it's like 3 days is still pretty good. What do you guys think? Right, you're never wrong to repeat. I'll tell you, if you repeat this, it's gonna be the exact same. And then peripheral smear is gonna be completely normal. I think stopping the heparin flushes and the PICC line and all that stuff is pretty aggressive. And I don't think she needs a transfusion. So I would just sit back and relax on this one and steal some pizza. And the reason for that is how many units or how many platelets are in a unit of blood? 0. There's not any platelets in a unit of blood. So if you transfuse somebody with a pretty big bleed, whether it be a trauma or a diverticular bleed, you're going to dilute out that platelet count afterwards. So this patient got 3 units of packed cells. I fully anticipate that in the next CBC that platelet count is going to be lower. That doesn't mean that they just had heparin-induced thrombocytopenia or they just developed something else. That's probably just hemodilution from all the packed cells that we've given. So here's some extra credit for you. Which of the following labs, again, I was a med tech prior to PA school, so I love labs. Which of the following labs would decrease with a few units of blood? Potassium, bilirubin, white cells, calcium, or AST. So after mass transfusion, so big traumas or diverticular bleeds, we give a bunch of units of blood. What goes down? couple different answers here. I would argue that the answer here is calcium. Calcium is going to go down because of the heparin and the citrate that's also in the unit of blood. So the citrate that's in the unit of blood is going to bind the calcium in the body. So if you check a calcium on a patient post-transfusion, it's probably going to be down. We talked about earlier, white blood or a transfusion or a unit of blood is going to have a lot of potassium in it. And so that should go up. Same with bilirubin. So if there's live blood and dead blood in a unit of blood, you're going to be giving someone, in theory, bilirubin into their arm. White cells, you can talk about leukoreduction or irradiated blood, and maybe there's not a lot of white cells, but the physiologic stress of receiving a transfusion is probably going to drive up the white count. And then AST, we all think about AST, and I could talk about this for hours as well. As every time we see AST, we're like, oh, liver enzyme, liver problem, liver. It's not. And then when we talk about liver function test, AST tells you 0 about liver function. So AST is also very potent inside red blood cells and skeletal muscle. So AST could go up with a transfusion as well. All right, here's the next one. Here's Mrs. Chemo. So Mrs. Chemo has large B-cell lymphoma. She's got a portacath in. She's just finished up a R-CHOP cycle, and she's bleeding. She's in the hospital. Her hemoglobin is 71. Her white cells, she's neutropenic or leukopenic. She's also pretty profoundly thrombocytopenic, but otherwise everything else looks okay. So what's your next step on her? We know this is R-CHOP, so pretty nasty chemotherapy. And what do you want to do? Peripheral smear, transfuse some platelets, prednisone, IVIG, or GCSF. Yeah, exactly, right? So we got a symptomatic patient with platelet count below 10,000, she needs a unit. So this is the case where you would transfuse platelets. Typically 20,000 is about your threshold. And these chemo patients, especially if they spike a fever, are medicine patients on the general floor. 10,000 is kind of where our cutoff, 10 to 20,000. You can spontaneously start bleeding around 20,000, but if you have a central line or something like that, you want to lean a little bit closer to 20,000. So she's below 20,000. She's a cancer patient. She needs platelets. So I would give a unit of platelets here. That's absolutely right. When we talk about transfusing platelets, 1 apheresis unit of platelets is about 4 to 6 units of whole blood. AABA, so the American Academy of Blood Banks, again, this is all going to lean a little bit more toward the states as far as evidence, but they all lean towards keeping that platelet count above 10,000. You got a central line, which most chemo patients will have, 20,000. If you're going to do any procedures on a hospitalized patient, like an LP or surgeries, you want 50. And then just remember, platelets carry the highest risk of infection. And the reason being is that platelets are stored at room temperature. So they have the best chance of breeding bacteria and all sorts of other stuff. So a lot of times your risk of fever with platelets is much higher than with packed units of red cells or anything like that. All right. So those are some fastballs covering some of the basics. Here comes a little bit harder one. So this is Mr. Ito. Mr. Ito drinks a lot of alcohol and smokes a lot of cigarettes. Not a lot of people, he's estranged from all of his family. Not a lot of people know much about him. He's had no surgeries that we're aware of. We don't know if he's taken any medications. So in the middle of July in Minnesota, which it still can get, we can get some 90 to 100 degree days there, but he was outside cutting his grass in winter boots, winter coat, winter gloves, winter hat. And his neighbors was like, I think he's drunk again or something's going on. And they called the police. So he ended up getting a ride to the emergency room where he had this mess of labs. So he's got anemia, he's got macrocytosis, he's got thrombocytopenia, he's got hyponatremia, he's got an AKI, he's got azotemia, he's got transaminitis, he's got lactic acidosis, he's got INR that's up as well. So nobody really knows what's going on with him. Well, he gets admitted in the middle of the night by our admitting team under the assumption that this is alcohol withdrawal. So he got a banana bag, he was placed on CEWA and admitted to medicine, so us. So when we came in the morning around 7 a.m., the nurse was calling and she said, he's agitated, he's shaky, he's confused, what do you want to do? So this is outside of the CEWA that she's already managing. Do we give him some Ativan, stat head CT, lactulose and rifaximin, empiric vancomycin, ceftriaxone, acyclovir, and abdominal CT? A couple of people are saying a head CT. That's a great answer. But what ended up happening is because we were busy and because everything else was going on, this patient was like, oh, let's just give him a little bit of Ativan. So the patient got Ativan. In addition to the Ativan, the patient was already getting for the CEWA protocol. And the plan was that our team was going to get there as soon as we could. which is not a good plan and why I use this case for teaching so much. But the patient he was still agitated, and the RN called again. I've given him the Ativan from the CWA. Do you guys know CWA, right? CWA, yeah. We've given the Ativan for CWA. I've given him extra Ativan. Something's not right. He's still agitated. So she calls again, and we say, what do you want to do here? Some more Ativan, a lumbar puncture, repeat the lactate, abdominal CT, stat head CT, or calm the nurse down a little bit. We're already kind of talking a little bit about the head CT here, and that's the right answer. And so when we got to the room finally, actually, when I walked into this room, and why I use this case for teaching all of the time, is that as I walked into the room to say, like, come on, what's going on here? He started posturing right in front of my eyes, which is a horrific sign. And unfortunately, this gentleman had fallen and hit his head, which nobody knew about, in the setting of a very coagulopathic laboratory profile from all the alcohol he was drinking. So yes, he was withdrawing from alcohol, but he also had no platelets and a super therapeutic INR and fell on his head, and now had a big subdural bleed, and was treated and billed as alcohol the whole time through a busy, this is even at Mayo Clinic, a busy emergency room, a busy general floor, a busy medical wing, and no one got the head CT. And we learned a lot from this case, that obviously not everyone with alcohol withdrawal with low platelets needs a head CT, but boy, sure would have been helpful on this guy. Not that we would have probably been able to change the management too much there, but maybe we could have done a few things. So anyway, the family finally were able to find out, and they came in and agreed to an autopsy to figure out what had happened. Well, he had underlying cirrhosis, which obviously we knew, at least from the neighbors talking about all the alcohol, and then he also had lung cancer from his smoking, and then he had the head trauma and the subdural. So liver disease plus alcohol plus malignancy plus trauma. It's a horrible setup for platelet counts. So when we talk about alcohol and platelets, alcohol after like 1 or 2 beers decreases your platelet aggregation. So about 20 minutes after ingestion. The first cell line that it takes out is a megakaryocyte. So very common, somebody binges on alcohol, they're going to have a low platelet count. It causes liver disease and splenomegaly, which we'll talk about later in this presentation. It accelerates platelet apoptosis, so it makes platelets die faster, so they don't live as much. And it decreases TPO, which is a hormone that tells your body when your platelets are low. And then when we talk about extra credit, MCV goes up. So we have big plump red cells because we're not getting, our diet is so poor with alcohol. And we're not getting a lot of folate. And then the AST to ALT ratio, that 2 to 1 and typically less than 300, that's like a slam dunk from alcohol. You cannot get that profile, AST to ALT, 2 to 1, less than 300, from Starbucks or anything like that. That's alcohol when they come in, and you see that. And then the magnesium is typically down. A lot of these patients will probably have diarrhea, and again, poor appetite as well. So we talk about this patient had alcohol, and in addition to that had some DIC. So DIC can come from sepsis, malignancy, trauma, infection, and we'll talk about that a little bit more, but disseminated intravascular coagulopathies, which is pretty scary. So what is this DIC? So DIC is a very scary thing in hospitalized patients. Usually it causes blood clotting and bleeding at the same time. Blood exposed to some kind of procoagulant like a tissue factor and LPS. So talk about tissue factor. In the case of our gentleman here, Mr. Ito, he's bleeding into his brain. So blood where it shouldn't be. So you have some kind of bad trauma, blood gets into spaces that it shouldn't. That tissue factor then sets off this DIC cascade, which is horrific to manage. And then in addition, it's the gram-negative people that come in. So they have some kind of gram-negative infection. You're not seeing DIC with MRSA, or rarely are you seeing that. It's always Klebsiella or E. coli or something like that. It's because of that lipopolysaccharide that's on the gram-negative bacteria that for some reason trigger this acute DIC. And then, it's acute versus chronic. So a lot of us probably in here have taken care of an acute DIC, which is just absolute mess to take care of. And you do your best. If they're clotting, you try to thin them out. If they're bleeding, you try to stop the bleeding. And then ultimately you need to fix the underlying problem. So in Mr. Ito's case, it was the head trauma. There was no chance. The patient actually ended up passing away in the ICU before long. But on sometimes supportive care and then treating the underlying cause, you can get yourself out of it. And then the chronic cases are the ones that patients maybe has this smoldering colon cancer where the tumor has exposed some tissue factor or a brain tumor or something like that, where it's just a mildly low platelet count and a mildly elevated INR. So we talked about management, treat the underlying disorder as primary. So if it's an infection, you got to treat that. If they're head bleed, you got to treat that. If there's something in their lung, you got to treat that. And then if they're clotting, how do you manage it? And if they're bleeding, you know, replacing clotting factors, FFP, platelets, things like that. We tried all of that with Mr. Ito, and unfortunately, again, it was too late with him. All right, here's this one. This is Mrs. Sofa. So she's 45. She's a female. She's got diabetes. She's got a fever, back pain, and dysuria. So it sounds a lot like pyelonephritis to me. She's got normal vitals other than a fever. She's confused on exam. Her platelets are 20,000. Her hemoglobin is down to 78, and her white count's pretty high at 17,000. Her AST, ALT, creatinine, all normal. You get a peripheral smear, you're seeing schistocytes. So there you go, like those helmet cells or those broken red blood cells. What is the most likely diagnosis for her? So is this TTP? Is this HUS? Is this DIC from sepsis? Is this ITP? Or I have no idea, I need more labs. You can probably make the diagnosis right now, but we'll give you some more labs because it's a lab presentation. So her INR is elevated. It's 1.8. Her LDH is elevated. Her Coombs test is negative. Her D-dimer is elevated and her fibrinogen is low. So those are all your coags. This is getting into the weeds a little bit more with thrombocytopenia. These are tougher cases. So now you have all of that information. What is this? TTP, HUS, DIC, ITP, or wait a second, what are you talking about again? Yep, this is DIC. So how do we know this one's DIC? Right here. So when you're starting to see thrombocytopenia and the elevated INR in a patient not on anticoagulation, and then coag factors like fibrinogen being low, so that combo right there would make me think DIC. And then this was a gram-negative bacteria infection. And then why you're seeing some of this hemolytic pattern is that MAHA type of, or that microangiopathic hemolytic anemia, which would cause the LDH to go up because you're lysing a bunch of cells. So again, the key is thrombocytopenia, INR that's up, patient's not on warfarin or DOACs or anything like that, and then a low fibrinogen. Fibrinogen is an acute phase reactant. So when you're sick, it should go up. So if you're sick and it's low, it's telling you that's pretty diagnostic that something's going on here. All right, here's Mrs. College. So Mrs. College is mid-20s, Caucasian female. She's got exercise-induced asthma and some reflux. She's had an ankle fracture from volleyball that was repaired. She's on Prilosec, albuterol, but she doesn't really take it too much, and then birth control. She goes to the local college just outside of Rochester, about 40 miles outside of Rochester. She says, yeah, I was binge drinking last night at an 80s party, and now I got a really sore throat and some fevers, and my body hurts, and I'm having some abdominal pain. So she was feeling terrible and went to the emergency room. When she got to the emergency room, she's got a leukocytosis. She's got a thrombocytopenia that's pretty decent. She's got that AST to ALT ratio that we were talking about, so that alcohol ratio. And then on peripheral smear, she's got reactive lymphocytes and thrombocytopenia, so an abnormal peripheral smear. She gets kind of we call it the flu-rona swab, but influenza, COVID, RSV, kind of that respiratory swab, all of those are negative. But she doesn't have the flu, she doesn't have COVID, she doesn't have RSV, she doesn't have strep. But she's got belly pain, she's got reactive lymphocytes, she's got thrombocytopenia, she's got some alcohol changes there. My question to you is, what do you want to do for her next? Does she need blood cultures, saline bolus, empiric vancomycin because she's septic? She just need to put her on CWAP protocol and get her away from the alcohol, and this will all kind of get better. Does she need a Woods lap exam and then check her iPhone, kind of like we did with Mr. Millennial back in the previous presentation? Is this maybe DIC and we should check an INR and some fibrinogen, or should we call her mom? So you guys know I like to add some twists to it, but we'll end up checking her phone. And she had like this, she was at this 80s party, which is like my decade. So I was like, that's pretty awesome. So she went to that. But do you guys know how to get shots to glow like that under a black light? quinine or tonic water usually will do that. And so quinine's pretty, I didn't know that, but quinine's pretty tough on platelets. And then in addition to that, she also had Epstein-Barr virus. She also had mono. So she's out drinking quinine and had mono from college. Obviously, it was running rampant. But she had splenomegaly, which is why she had an abdominal pain. And so the teaching points on this case obviously exaggerated and some curveballs thrown there. But splenomegaly will also cause low platelets. If you think about how the platelets in the peripheral blood, 20 to 40% of them are sequestered in the spleen at all times. So if you give yourself a big spleen, alcohol, portal hypertension, Epstein-Barr virus, lymphoma, those things will cause you to have thrombocytopenia. So not uncommon to see thrombocytopenia in these patients. So that's kind of, she had a bunch of reasons there. Quinine from the black light shots. She had Epstein-Barr virus infection from mono, and then she was drinking some alcohol. All right, here's Mr. Seymour. So Mr. Seymour is named after my home state, which is Wisconsin. I don't know if you guys are familiar with that state, but we're known for beer and cheese and hamburgers and all of that. But he lives there, and he has hyperlipidemia and BPH. He's had his knee was fixed. He's on simvastatin and Flomax, and this guy came in pretty sick. So he's febrile, he's confused, he's having bloody stools. So he shows up and his labs look pretty nasty. So he's got anemia, leukocytosis, thrombocytopenia, so kind of similar to everybody else. He's got AST is up, but that ALT is okay. So elevated AST, but a normal ALT. We talked a little bit about liver enzymes previously. So ALT, more sensitive and specific to the liver. So that's a little hint there. The bilirubin is high. The INR is normal. His fibrinogen is normal. His Coombs is negative, and he's got schistocytes and thrombocytopenia. So which three-letter one is this? Is this HUS, DIC, TTP, HIT, LOL, or I don't know? A is a good thought. It's actually C, TTP. So A, or hemolytic uremic syndrome is the very similar presentation, but the age of the patient is a little bit. So HUS typically is going to be occurring in the younger adult or younger kids. And this one's a TTP. Very similar presentation, very similar physiology behind the both. But this patient had in Seymour, Wisconsin, they think they're famous for inventing the hamburger or the hamburger introduction to America. And so they have this festival every year where they try to cook the biggest hamburger. I know, textbook American right now. But they try to cook the biggest hamburger on this huge frying, and then everyone kind of touches it with their hands and eats some of it. It's just a terrible idea. And this patient had an E. coli infection from that festival and was pretty sick with TTP. So how do we know this one's TTP compared to all the other ones? And I would just draw your attention. So again, we're seeing this consistent thing here. So we got the anemia. And again, that's typically like this MAHA anemia or microangiopathic hemolytic anemia. So these syndromes cause vasoconstriction and these red cells try to get through there and then they break open. So you're seeing some hemolysis type changes on the labs. So hemoglobin's dropping, patients are sick, potassium could go up, AST could go up, the peripheral smear is showing schistocytes. So that happens in DIC, it happens in HUS, it happens in TTP. But the differentiating factors between this case and the prior ones is that this patient's coag studies are all normal. So his INR is normal, his fibrinogen is normal. And then this patient started having some other things that the other patients didn't have. This guy was confused. He was just didn't look as well. He was febrile. And so again, that's hard to tease out because you're like, well, the pyelo patient could also be confused. But I would, again, hang my hat on the fact that this patient has normal coag. And that's why I would be leaning a little bit more towards TTP here. So here's a chart that you can just reference in your handout as far as differentiating those, things to be scared about. But my question to you is, we know this is TTP. How do we manage this? Do we check an Adams 13? Do we initiate plasma exchange? Do we give DEX? Do we transfuse platelets? Do we watch the Adams family? Do we draft Devontae Adams? Do we watch Amy Adams? Or enough with the Adams stuff? If we know it's TTP and we're pretty confident, then we should go right to plasma exchange because that's going to save this patient's life. So if we mess around and we say, well, we should get the definitive diagnosis and we should check the Adams 13 level, at Mayo Clinic in Rochester, I can get an Adams 13 level pretty fast. Like I said, we're spoiled brats there. We have access to MRIs and CT scans on Saturday and Sunday and in the middle of the night. We can do all of that. We can get dialysis. We can get an Adams 13 level. But if you're practicing real medicine and you're outside of, being able to get that lab back, if you're nervous that they have TTP, the thing that's going to save their life is plasma exchange. So getting on the phone with hematology or getting them to a place that they can get plasma exchange is going to change the outcome for that patient. So that the answer there would be start plasma exchange. If you think it's TTP and you call heme and you say, hey, I think this patient needs plasma exchange. If you're wrong, you're probably not going to, not that big of a deal. You're probably going to have an upset hematologist and you've mobilized a lot of resources. But if you're right, you've saved their life. So when we talk about standard management of TTP, the plasma exchange, it's 90% effective. And you just keep doing that until the platelets have stayed normal for 48 hours. We can try some steroids. You can try some rituximab, some red blood cell transfusions, all that other stuff. That's all supportive care type of thing. The key is you don't want to load these patients up with platelets, right? Because you're just having autoantibodies to all these platelets. So you're adding gasoline to a fire. So you want to get plasma exchange. You want to clear out all those autoantibodies so they stop attacking the platelets. Causes of TTP, drugs, Plavix, cyclosporin, infections, pregnancy, autoimmune disorders, malignancy, stem cells. We talk about in the books, the classic PENTAD, which is that MAHA that we talked about, the microangiopathic hemolytic anemia, the thrombocytopenia, the fever, mental status changes in the AKI. That can happen with DK or with DIC as well, but that's typically what you're going to see. But when you think about what you actually see is probably the MAHA, thrombocytopenia, and then the absence of an alternative explanation. There's this plasmic score for if you're into calculating, and you can just use like MedCalc or things like that online to help kind of fill all of that out. But this person's plasmic score was going to be a 7 based on all that. The platelet count being low, patient had hemolysis, no cancer, no transplant. The MCV was low, the creatinine was up, and the INR was normal. So plasmic score is 7, high risk. Don't need to get the Adams 13. Don't waste your time waiting for that test. Call hematology, get them somewhere where they can get plasma exchange. All right, last one. Here's Mrs. Heparin. She's 75 years old, female, recently diagnosed with a right leg DVT after orthopedic surgery for a femur fracture. She gets discharged with a hemoglobin 140, white count of 6, platelet count of 360,000. So textbook, post-op, DVT, discharge. She was placed on unfractionated heparin to start with, transitioned to Lovenox, and now she's at a skilled nursing facility locally in town. She comes back 1 week later and her left arm is all swollen. An ultrasound shows a new DVT in the left arm, and her hemoglobin is 13, her white count is 8, and her platelets are 130,000. So my question to you is this HIT type 1, HIT type 2, DIC, TTP, or did she just get a COVID vaccine and that's why she has this? This one's HIT type 2. So what we think about a lot of times is when we think about heparin-induced thrombocytopenia, we're always like, oh, that's the scary one. That's the one that can kill you. That obviously should be 1, but it's actually not. I mean, obviously, a lot of times people don't break down between type 1 and type 2, but HIT type 1 is just after exposure to heparin. So you give somebody heparin in the hospital, the next day you check their platelets. Platelets hate heparin, so their platelet count's probably going to drop. Not that much, couple 20,000, 30,000. They've been exposed to heparin, doesn't worry me one bit. Totally expected. Versus HIT type 2 is about 5 days after exposure and a big reduction. So 50% reduction in platelet count. And then a lot of times can be a new blood clot somewhere. So when we talk about scoring things, and if you want, again, this is MedCalc, but the 4T scoring system for heparin-induced thrombocytopenia, again, her total score was 6 to 8. So it's a high score here. She had an acute onset thrombocytopenia about 5 days after exposure. And then a new blood clot there. So those were big score points for her there. When we talk about management for heparin-induced thrombocytopenia, obviously you need to stop the heparin. The PF4 antibody and the serotonin release assay, again, these are probably big time academic medical center spoiled having the ability to get these tests. Do you need these tests to make this diagnosis? No. Sometimes they're helpful. Sometimes if you're confused, you can get them, but sometimes they take a while to get those tests back. Agatroban and Bival are kind of your anticoagulants that you can use. If they have renal issues, you want to use Agatroban and then transition them to warfarin. If they have hepatic issues, you use Bival and transition them to like Eliquis or Rixtra or something like that. And then DOACs are okay. You treat 4 weeks to 3 months. So if the patient just has heparin-induced thrombocytopenia with no clot, you can stop after 4 weeks. But if they clot, you need to treat for a provoked DVT. So that's 3 months of treatment. If you miss this, 1 out of 5 people are going to die. And so the scary thing is it's really easy when their platelet count goes from 300 or 400,000 down to 50,000. And you're like, holy cow, something just happened. The tough ones are when they're normal and they go from 400,000 down to 200,000 and nothing picks that up. And so we use Epic at Mayo, and Epic, they built in some, that's our electronic medical record. They built in some flags for that. So even if the platelet count is normal and it drops 50%, we get a flag that says, hey, have you considered heparin-induced thrombocytopenia or something like that? And you have to acknowledge the fact that you recognize there's been a 50% reduction in platelet count. This typically is going to happen more with unfractionated heparin than it is with low molecular weight heparin. So these patients on unfractionated heparin drips. And then typically going to happen more with treatment doses, these patients that we put on the drip, not the ones that were given 5,000 units TID to prevent DVTs. And then for some reason, it happens with females more than males. Oof. All right, you guys are experts on thrombocytopenia. So just to run the list again and review here. So we have Mr. Spots. So Mr. Spots came in, he wasn't that sick, right? So we're not that concerned. He's got isolated thrombocytopenia. So nothing else is really going on with him. And then he's got petechiae on his feet. We didn't really talk about that, but petechiae always are going to show up on areas of high gravity. So if you're looking for petechiae, it's not going to be on your hands. And then in the hospital, sometimes patients that have elevated feet or legs, you got to actually move the patient over and look on the backside because that's where the petechiae are going to show, because little oozing from the platelet or low platelets are going to form on the areas of gravity. And so that's why he had him on his feet. He was okay. It was only the platelets that were low. And so then the decision point is, does he need treatment or not? And according to the American Society of Hematology, if they're less than 30,000, then yes, they would benefit from some treatment. And then does he need treatment at home or does he need treatment in the hospital? If you went evidence-based, 20,000 is your cutoff. So this guy could go home. But like we talked about earlier, if patients don't read the books, maybe this is someone that you don't trust is going to do well outpatient. Obviously, you can hospitalize them and then just keep an eye on them after initiation of steroids to make sure the platelets start to come back up. If they don't, then that triggers the hematology consult down the road. We talk about Mrs. Spots. Obviously, ITP isn't contagious. And her case was just to show you that sometimes traumatic venous puncture, which, we have a ton of that in the hospital, patients that have medically complicated obesity or difficult blood draws are going to have that traumatic draw, or maybe they have an EDTA dependent allergy. Those patients just redraw the platelet count in a citrate tube. Mrs. Popcorn, she was our diverticular bleed, if you remember. A lot of times we give people just whole blood or units of blood, transfuse them. 1 unit, not that big of a deal, but if you start giving 3, 4, 5 units of blood, not uncommon to see that platelet count drop the next day when you're checking that CBC. This is chemo. Totally expected in her case, right? She's on chemotherapy, which is kind of causes pancytopenia. The teaching point on her was that 10,000 kind of cutoff, especially if they're symptomatic with epistaxis. They got a central line, 20,000. If you need a procedure, 50,000. And then just remember, platelets are extremely high risk because they just sit there in room temperature. So they breed bacteria and hang out there. Mr. Alcohol or Mr. Ito, alcohol can do this. This was also a DIC with the head bleed, and then the super therapeutic INR as well, or the coagulopathy from liver disease. Mrs. Sofa, she was our gram-negative sepsis. So remember that gram-negative bacteria has that LPS, which can trigger acute DIC. Remember, in DIC, your coagulation parameters are going to be off versus the other one like HUS and TTP, those coag studies are going to be normal. And then this is college. So anything that causes splenomegaly will also cause thrombocytopenia. So if we got Epstein-Barr virus, if we got lymphoma, if we got portal hypertension or something that causes the spleen to get bigger, you're going to sequester more platelets in that big spleen. Mr. Seymour, he was the gentleman who unfortunately got like an E. coli 0157 or some sort of bad HUS or TTP causing bacteria. The key on those patients is if you're thinking TTP, make that call, make sure they're there, because you can change the outcome with plasmapheresis versus if you're waiting for that Adams 13 level to come back or something like that. And then Mrs. Heparin, just remember the two types of heparin-induced thrombocytopenia. That initial exposure, if you start someone on a heparin drip, their platelet count's going to probably drop the next day. That's type 1, 24 hours, probably going to go down, not too worried. But 5 days after exposure, 50% reduction, these are patients you should be nervous about. Not all of them are going to clot, but a lot of them will. If they don't clot, 4 weeks of an alternate anticoagulant, they should be good to go. And then obviously avoid heparin in the future. If they do clot, then they need 3 months of treatment with something like a DOAC or something like that. Whew, that's a lot of information, but hopefully it was helpful for you guys. My email is right there if you want to email. I don't know where I'm at on time. I got 5 minutes. So I can take questions, or you can email me questions, or I'm going to hang out a little bit, but back to the US tomorrow morning. But appreciate everyone's attention. That went a lot smoother with the ARS. So thanks for hanging in there. I know it's tough after lunch to come back. So hopefully it was educational for you. Thank you.